All right.
Wonderful. Well, good evening, everybody. Welcome to SeminoleTech. Thank you so much for joining us this evening. I'm Kate Crockett. I'm the chair of SeminoleTech this year, and I am with RB Advisory, cybersecurity firm. So welcome. Jessica, if you go to the next slide. I want to say thank you right now to our sponsors, Coulter Solutions and Complete Communications. Is there a representative by chance on with us from Coulter Solutions?
Don't believe so.
And Rob, are you on with us from Complete Communications?
Guess not.
All right, well then go to the next slide. So if you would, of course, we always like for people to go onto our social media, Facebook and LinkedIn, hashtag SeminoleTech. You can take some pictures tonight, post it online. Make sure you go online and also like our page and just interact with us as much as possible. We would greatly appreciate it. We have some Seminole Chamber events, the upcoming events. Tomorrow morning will be Good Morning Seminole. All of our council meetups, chamber use coming up. This is after hours. So make sure you get onto the website at the bottom for the events and register for as many chamber events. The more you get involved in the chamber, the more you see the referrals coming back and the more commerce happens. So definitely I would encourage you to go to as many chamber events as possible. A couple of other events that are going on the next page that will become upcoming, some ribbon cuttings and some other events. So make sure you get involved with that. We have a creative, effective Facebook ads presented by Countess Group tomorrow. Sweet Bites and Bikes on September 5th. And then Kids Night Out at Nailed It, DIY in Lake Mary, a Grandparents' Day edition on September 11th, which sounds like a lot of fun. So we're going to hop right into things this evening. This month we have sports medicine technology, which is really interesting. I was an athlete, so it kind of hits home to me. But we've got three great speakers this evening to kind of give us some information on some of the technology behind sports medicine. And if you have any injuries or anything like that, this is probably the place to be tonight. So we're going to get started with our first speaker. I want to thank Dr. Louis Gandara from Jewett Orthopaedic Clinic, Orlando Health. And if you would, Dr. Gandara, please get your presentation ready and we'll get on started. Thank you so much. I hope everybody enjoys the presentation this evening.
And as a reminder, just please stay on mute while the presenter is speaking as well.
All right. Can everybody see it on the screen right now? Okay, good. So good evening, everybody. It's a pleasure to give this presentation today. My name is Dr. Gandara from Jewett Orthopaedics, Lake Mary office, Orlando Health. I'll be talking today about the wonderful platelet-rich plasma procedure and also how we are using the ultrasound on sports medicine in the clinic and also on the sidelines when we're covering sports activities. So my training is basically on physical medicine rehab, which we call that physiatry in the United States, but I have a fellowship on sports medicine. I currently practice as a non-surgical sport medicine for the Jewett Orthopaedic Clinic. So today I'm going to try to discuss what is the science behind the PRP, what it does involve, what are the uses, indications, contraindications, and I'm going to discuss some of the research in the past that shows how effective this has been on some athletes for certain conditions. And also at the last part, we're going to talk about the sonogram and sport medicine. So PRP, which is platelet-rich plasma, is a procedure that we use to place the patient on blood. it has some advantage in terms of try to heal some chronic inflamed tissues, like people with chronic tendinitis. It's minimally invasive, and again, it's using the same blood of the patient. So the patient stayed at the office, and it takes about somewhere 20-25 minutes. How we obtain this this product from the patient? So after we take a blood sample from the patient in the office, it's placed on a centrifuge machine. In my case, I use the machine on the screen. That machine spins the blood for about 15 minutes, and it separates the plasma from the platelets. The platelets, you're gonna see the next screen, is only a tiny amount of blood compared to what we obtain from the patient. The concentration of platelets that we obtain is usually 3 to 5 times the amount of platelets the patient has. And these are the platelets then it's get injected into the patient. It will be a tendon, ligament. Sometimes we inject the joint for people with arthritis. Next one here. So this is typically the flow of the PRP. So first we collect the blood sample from the patient. It depending on the indication or the location of the injection, we take certain volume of blood. It can be from 30 mL to 60 mL of blood. It goes to the machine, spin, and then we extract the platelets, and then we inject it. So this is how it looks when you obtain the platelet after you finish the centrifuge from spinning. So you can see the top yellow part here, that's the plasma. That doesn't have any platelets, just like water content. And the middle is the buffy coat. That's the concentration of platelet with white blood cells. The bottom part is just only the red blood cells. So this tiny amount here in the middle part, that's what we obtain or what we use as a platelet-rich plasma. What we know is the platelets has several growth factors. There's small granules that when the platelets gets in contact with tissue, this growth factors get released, promoting tissue remodeling, healing, and the cells to differentiate, hopefully cause some tissue regeneration and decrease inflammation. As you can see, most of the blood is made of plasma, and the rest are the elements of the platelets, white blood cells, and others. So platelets, like I explained before, it's a small cell. The main job of the platelets are to, when people are bleeding, they're the ones that start the bleeding process. So works in a coagulation cascade. And again, they release the growth factors which helps on healing or tissue regeneration. The growth factors, there are different ones. There are different types, which I'm going to explain next here. But the goal is to cause an inflammation that leads to cell proliferation. It causes differentiation of the cell. It then leads to tissue regeneration and hopefully the tendon, ligament, or wound healing. There are two main ones. The growth factors are important when we do PRP, which are the main ones that we talk about most of the time. They are the platelet derived growth factor, or PDGF, and then transforming growth factor beta. Both of them works on new regeneration of blood vessels and also collagen, which is important for the tendons and sometimes the ligament too. And you see there all those works on increasing the amount of blood vessels to the area. This is a little diagram. It shows when we inject the platelets. You see number 1, it gets activated the inflammatory cascade. It attracts all the cells to activate on specifically on the tendon. It causes the cells to proliferate. It started making some collagen synthesis to produce new tissue. Hopefully, it goes all the way to tissue regeneration. Now, right now, the application of PRP it has expanded a lot in different areas. Mainly in my practice, I use it for rotator cuff tendinitis, rotator cuff partial tears, bursitis. It's used a lot for tennis elbow, called Garfield's elbow. Patella tendinitis is also that we use it in a great amount of cases. It's also in a lot of people that have chronic Achilles tendinitis, it has been used for that. Some patients that they don't want to go procedure for surgery for the knee or the hip for arthritis, they are asking to try the PRP injection, and I have done several of those too. And there's other areas that other colleagues of mine are doing it, like the spine, but I don't have any experience with the spine on PRP injections. next one here. So there's been several studies in the past. This is one that was done in 2011 at the American Journal of Sports Medicine, which it compared PRP with the cortisone injection group. They were treated before with a steroid or physical therapy in the past. It divided almost an equal amount of patients. It was injected with PRP one side, and the other group was do with steroid. Basically, what it shows in the PRP group, it shows a better improvement in pain symptoms when compared to steroid. It also improves significantly the function of the patient that had the PRP versus the steroid. This also study shows that as the time passed, the PRP group continued to improve better, where the steroid group initially only have a better response the first few months and then decline. So it shows that the platelets appears to continue working over time, and not like steroid that you only have like a increased response and then it just tends to fade away. There's another study for the elbow tendinitis with PRP, which it took several patients for being injected. One group was injected with numbing medication, which is called bupivacaine, and the other group was PRP. At 4 weeks, the PRP group had a great improvement, almost 46%, and the other one only have 70%. They also checked them out of 8 weeks, and they noted the PRP group was significantly improved compared to the numbing medication group. And 6 months later, the PRP continued showing significant improvement for tennis elbow. This is another research done, a randomized control trial. This was specifically for Achilles tendonitis, which basically they did PRP and normal saline injection on the Achilles tendon of different patients. And this specific study, it didn't show any improvement between both groups. In my experience with Achilles tendonitis, I would say 50% of chances of getting somebody better with PRP. For some reason, Achilles tendon, the blood flow is not that much great where people have the tendonitis distally, and the PRP sometimes works, but I have some patient that hasn't worked. So this is an area that we have to keep exploring. This is a study that they did PRP compared to the viscous supplementation injection, which is an injection they do for knee arthritis. They injected both groups, one group with PRP, another group with gel injections. And they were separated once injection per week for 3 weeks, and then followed them 2 6 months, and then at 12 months. And there was no major difference in terms of one was better than the other one. Both groups show improvement in pain and function. One thing that I've seen in the past in some studies is that PRP, after people with arthritis has been getting those injections, that arthritis has been stable, hasn't progressed as much. So who's a candidate for this treatment or PRP? So anybody who has a tendon, ligament injury, or any joint problems like arthritis, it will be a candidate. This is less aggressive than surgery. It's done in the office. It has minimal downtime, and the patient can resume activities soon, in about 4 or 6 weeks most of the time. There are some contraindications for this treatment. One is you have a low platelet count. If you have a genetic conditions called hypofibrinogenemia, if you have problem with your blood pressure, low blood pressure, or you don't feel dizzy, we try to avoid doing that procedure during that day. Anybody with infections, any chronic liver disease, or any patient with Coumadin or Plavix or any anticoagulation therapy, those are no because those inhibit the platelets. So technically, the procedure is not gonna work. The risks are minimal for PRP. Basically, infection is one of the risks. We always say the patient, since we're passing needle through the skin, there could be a nerve vascular damage if you don't pay attention where you're injecting. Some bruising can happen. Before the PRP, the patient, we set up the patient, they come in, they stop any anti-inflammatory medication. We tell them it's going to take about 25 minutes. And then after PRP, what we have them to do, tell them it's going to cause some pain at the initially 7 days due to the platelets causing an increased inflammatory response. I give the patient a protocol to do after the injection for the next 4 or 6 weeks. Typically, some response for the PRP is going to be somewhere about 6 weeks after the procedure, and that's when I get in touch with the patient to see if this is working or not. How many injections? It depends. I typically do 1, and then I wait about 6 weeks and see how the patient is responding. I want to see if the patient gets somewhere 70–80% improvement before I might consider another injections. Most patients with 1 injection do really well. Unfortunately, insurance company don't cover PRP since they categorize this as an experimental procedure. So right now, this is a self-pay procedure, and it has different costs across the country or whatever you go to ask for. So I'm gonna turn things to the ultrasound, which is something that the sport medicine doctors as me are using more often in the clinic and outside. So ultrasound now has become more portable. There's no exposure to X-rays. It's very inexpensive, non-invasive. It has helped a lot on the accuracy of injections, and also to make some diagnostics on certain areas that you require the patient to move the joint. With the sonogram, you can do a dynamic study and diagnose some pathology, which you can see with an X-ray or an MRI. So this is an example of some of the stuff I do in the office. I use the sonogram to do this type of injection. This, for example, is an injection in the shoulder. I want to show you how we inject. This is a needle here. This is called the bursa of the shoulder. So when people talk about bursitis, this is technically what we have to inject. This little space here on top of the tendon, which is here, this is the space that we're targeting. In the past, what we're doing is we're injecting blindly. So we imagine now, after you've seen this, how tiny is that small area that we're trying to inject. Well, with sonogram, we have improved significantly the outcomes and the accuracy of the injection by just seeing it and injecting it. In my experience, has made a big difference on the patient and also the results. Right now, sonograms has become more portable like this. This is a phone. You just download the app. You can connect the probe. It's been used in the silence in several areas. I have friends of mine that are using this portable phone sonogram. In the office, I use a portable sonogram like this. It's kind of laptop-wise. It has more power. This is some examples of what I do in the office. So this is an Achilles tendon. This is a normal tendon all the way down here. This is the bone. The tendon goes over here, so you can see. I can see the pattern, and this is changing the way of the what we call the probe on the sonogram. This is called a longitudinal view to see it in a long view, and the other one is called a short view. But this is a pretty normal tendon, and with sonogram, I can see that in the office and diagnose a problem. This is the person who had Achilles tendon rupture. So this one, something we see in the silence, or we can see in the clinic immediately with sonogram. Just put it on, and you can see this is the whole tendon, but it's ruptured right here in the middle. So the sonogram helps and make the accurate diagnosis right there. You don't have to go to MRI. It's simple, like you see, very easy to do. Sometimes also I use it in the silence, and we might be able to capture fracture. For example, this is a fracture of a kid, has a fracture to the wrist area right here. With sonogram, if I'm in the silence, I can put it on, and I can see a little step up on the cortex, which makes a speech of a fracture, and I can have the athlete stop right there, not play anymore, because I see that he might have a fracture. So it aids on diagnosis purposes in the sports world. And lastly, this is a procedure. It's very common performed in the office with the aid of the sonogram. This is called a calcific tendinitis. I see a lot of patients with this problem, and they come with significant pain in the shoulder. With the help of the sonogram, I'm able to localize the calcification. In this case, it's right in this area here by the tendon. And what I do, I use a sonogram to localize it, and then I guide the needle into the calcification. We try to break the calcification and aspirate the calcification stuff, end up having all this white calcific material there. The majority of patients, when I do this, they improve significantly within 3 to 5 days, and they don't require any more injections. But this is one of the procedures that I see that the patients are, after the procedure, they're very happy because it reduces significantly the pain. And this is a very painful condition. So having this handy and do it immediately, it works, and people are very, very pleased with the result after this. This is called a calcific tendinitis barbotage. So this is all information I provided to you guys today. Hopefully it was interesting. And I will be happy to answer any question at the end.
It looks like there is a question. Would this PRP treatment have any effect on other injuries, say, for example, cartilage damage?
So right now, there's been several studies have done in the past to see if PRP helps on the cartilage damage. Where there are different type of cartilage damage, there's one from wear down of the cartilage with people with osteoarthritis, and there's some people that have what is called cartilage defect from an injury. Like I see that on kids or younger patients. In people with osteoarthritis or cartilage loss because of arthritis, it doesn't work because we haven't seen any regeneration in the cartilage. Now, if somebody, let's say somebody young, less than 25 years old, had an injury and a piece of cartilage come off, or we call that osteochondral defect, those we have injected in the past, and I have seen some patients have recovered over that defect when we inject PRP. So I see a way of a treatment with PRP for some patients on this and that indication, but not for like cartilage loss because of arthritis.
Great. And another question, Mercedes said, I have a shredded tendon in my left leg. Can PRP treatment potentially be used in the legs? So
it can be a potential treatment. It depends on the severity. PRP usually will not do anything if the tendon is completely ruptured. Like what I mean, that is being detached. But if the tendon is still attached and there's some fibers working, or the person has a significant inflammation, it is potentially something that you can try, and it might be worth it trying, because other than that, surgery will be an option later on. But it's the same case in people with rotator cuff partial tears. We inject it, and we have seen some people that improve significantly.
And last question is, how long until you can return to your athletic activities?
So I would say it depends on the location and the injection. On average, usually about 6 weeks. Most people with lower extremity, uppers, they return a little more quicker, but on average it's about 6 weeks mark. Upper extremity about 4 weeks, but the downtime is not that long.
Wonderful. Well, thank you so much, Doctor. That was really great information. We appreciate your time this evening. Thank you for everything. We appreciate it.
No problem. You're welcome.
Wonderful. All right. Well, moving on to our next speaker, we have Dr. Angela Sehgal from Florida State University. She's the program director, the athletic training, and also the program director in health professions learning community. So I'll give her a moment to get her presentation up, and we will get going with that. Welcome, Doctor. Angela, you are still on mute. You can come there. You can go. Hello.
Hey, greetings from Tallahassee, everybody. You guys, this is my 4th class today on Zoom. So I've called for my students. I've told them it's a wacky Wednesday, and I've still got 2 more meetings after this one today. So I'll be lucky if I could figure out how to turn this thing off tonight.
Well, you're doing good so far.
So first of all, I'll start out like I do with my students, and I'll say we won't have a quiz today. So this is just, we're just here for fun. And Dr. Gandara was awesome. And believe it or not, I don't know him, but he set me up just perfectly for my presentation. So I just want to say thank you to everyone, Kate and Jessica, for the invitation, and to Andrea as well, my sister-in-law. So thank you. So I'm the athletic training program director at Florida State. We work hand in hand with physicians such as Dr. Gandara. We have physicians here in Tallahassee. And so we all kind of fall under the umbrella. So Dr. Gandara is in this area under the sports medicine umbrella, And my profession is athletic training. So we work hand in hand with our physicians. We are a medical profession. And this is what I tell people. We're the people that actually, you see us running out on the field when there's an injury, and we deal with physically active populations. We do rehab, we do triage situations, we do treatments, and I'm going to talk to you about a couple things that we're doing here at Florida State with our athletes, and I think it's kind of exciting, and I think a lot of people, you just see during game day, you see what's happening, but there's a lot going on a daily basis with our athletes behind the scenes. If anybody has a question as I'm going through, please don't hesitate to unmute yourself and ask me. So this is how I feel today. I feel like my tail's about to fall off, but you know, we're known for taping ankles, but as athletic trainers and working with our physicians, we do much more than that. But I think it's important to keep on laughing, certainly during this crazy time in our lives. So I'm just going to real quickly talk about a few things. And like I said, Dr. Gandara did just a fabulous job, because I'm going to talk to you about another set of injections that we do, including prolotherapy. So 10X is a system. Prolotherapy, I'll talk about what they call the HIVAMAT, and then the BIODEX. So I have no interest in these companies, and I have no bias, so that's just my disclaimer. All right, so we have, and some of you, and certainly feel free to interrupt me, some of you may have bone spurs or areas, just like, I mean, literally, Dr. Gandara was awesome because he set me right up. So there may be areas where, and again, he showed you on the ultrasound, or what we call the sonogram, where there may be deficits. Well, in the past, let's say, for example, you have tennis elbow. So if you have some spurring going on, in the past, our athletes have had to have a kind of a more invasive procedure where we've had to make surgical incisions, and our athletes are out, you know, for 4 to 6, maybe even 8 weeks. But our physicians in the orthopedic world here in Tallahassee and throughout the country are using a system called 10X. So this is a device where this is a needle, and again, it's vibrating with ultrasound frequency, and it's actually a bone spur removal system. But it's really neat because it's basically less than a mosquito bite kind of incision. And so it's really neat. They've been using this procedure on cataracts for many years as well. So, and again, I'm coming at this as an athletic trainer. I'm not a physician, but we've seen awesome results with this, particularly with overuse injuries. So what I would like to do is just briefly just show you a very quick video on this 10X system.
Chronic tendon pain. You've been living with it for months or even years. 10X Health TX is a simple 20-minute outpatient procedure which relies on ultrasound to accurately identify the area where your pain is located. Then the TX microtip is inserted through a tiny incision to break down and remove the pain-causing damaged tendon tissue. Surrounding healthy tissue is not disturbed, and the process stimulates a natural healing response. After your 10X Health TX procedure, a small bandage is applied and no stitches are needed. Please follow your physician's instructions and quickly return to the activities you enjoy.
So what's really nice about this procedure is that, again, there's really no real loss of time. We do have to, once our athletes have this procedure, we will allow that area to heal, and we'll do some other treatments as an adjunct therapy. But again, if you're having bone spurs, this may be an option for you, again, according to your healthcare provider. But we have had good success here at FSU with that. In regard to the PRP injections that Dr. Gandara was speaking about, we also are doing something we are doing PRP therapy with our athletes, but we're also doing a injection series called prolotherapy. So probably all of us in this group have probably had some type of tendonitis, and tendonitis is kind of that overuse kind of a condition. And so what we're doing is a little different than PRP or cortisone. What we're doing is dextrose is a sugar, and we're actually, this is kind of, it seems kind of counterintuitive, but we're injecting sugar into the tendon to actually promote the inflammation process. So what we're trying to say is we're irritating that tendon on purpose so that it'll lay down and fill in the collagen and kind of ignite or have a catalyst for that inflammatory process. And so we're using dextrose injections. We're doing this for tendons. We're actually doing it for low back pain to actually help the sacroiliac area to strengthen and to, so anyways, we're doing this in the same manner that Dr. Gandara laid out as far as under ultrasound guidance. So our physicians can see where the deficits are. They'll lay that dextrose in there, and then this is a series typically of 3 injections, typically about 3 to 4 weeks apart. And like I tell my students, we always try to have good news with this. The good news is most insurance companies will cover this. So it's usually covered within your, it's not considered experimental with most insurance companies. So it is covered. And this is a sugar injection. And so again, we're looking for the inflammation process. You cannot take anti-inflammatory, so you won't be able, you can take Tylenol, but we actually want the inflammation process to occur. The pain is minimal, like Dr. Gandara said, that, you know, inside of injection, you might have a little pain and discomfort, but again, so we use what we call prolotherapy here at FSU. And let me advance to the next slide, and we'll watch this.
Prolotherapy is a non-surgical regenerative injection treatment used to aid in the repairing of tendons, ligaments, and joints after an injury has occurred. A solution is injected directly into weak or damaged soft tissue, which stimulates an inflammatory response to promote the body's own healing mechanism for proper ligament and tendon repair and stability. Prolotherapy can effectively be used to treat musculoskeletal conditions and can ultimately be used as an alternative to major surgeries and/or prescribed medications, which can aid in the overall improvement of functionality, mobility, muscle and tendon strength, pain, stiffness, and muscle spasms.
So again, that may be an option, and sometimes, and again, according to your physician and what your situation is, even the prolotherapy may be able just to buy us time. So during a season, just let me give you an example. Football season's getting ready to start here next week. So if we have an athlete that's kind of on that borderline, sometimes maybe prolotherapy can buy us time to get them through the season. And then if they need surgery later on, that can get us through. So sometimes we can use this in adjunct with other therapies or surgery later on. Let me continue.
Prolotherapy.
Oh, let me keep going. Now, this is a pretty neat technology we have, which is pretty cool. This is called the HIVAMAT, or if you're in the South, we can call it HIVAMAT. I can say y'all. I always say y'all. Oh, wait a minute. Let's see. So let's see here. So we're got the HIVAMAT going. So basically, the athletic trainer or the therapist, physical therapy clinics also have this. But what happens, you see this right here. This is an electrical electrode here. That the therapist actually, or the athletic trainer, is a part of the electrical circuit. There is electricity coming out of her hands. And so what we can use, the indications for the HIVAMAT, for swelling, muscle soreness. I've even talked to groups following breast cancer surgery, like poor lymphatic flow. We can use electricity and this massaging technique and move that fluid back toward the heart, so distal to proximal. So again, we can use electricity flowing through us and onto the patient to act. It's a pretty neat process, but we can do that for muscle soreness again and swelling. So it aids in recovery particularly from athletic injuries. So we do a lot of these treatments here at FSU. And again, we can take this on the road with us as well. But you will see that electricity is coming through her hands. So we'll go to the next slide.
Acute soft tissue injuries are commonplace among athletes. Such injuries are painful and keep athletes from performing their best if they can continue to perform at all. In these cases, where acute traumatic injury occurs, swelling must be controlled in order to retain range of motion, reduce pain, and aid the healing process. For athletes, being treated with the HIVAMAT 200 evident deep oscillation therapy directly acts on contusions, edema, hematomas, and other effects of soft tissue trauma to relieve excess fluid by activating the lymphatic system. First, by dissolving lymphatic waste, then by relaxing the muscles, and finally, by helping to remove the accumulations from the afflicted area. HIVAMAT deep oscillation treatment lasts typically around 20 minutes, delivering a massaging sensation deep into the soft tissues while being comfortable enough to treat even the most sensitive of injuries. It is even safe for post-operative care. HIVAMAT deep oscillation therapy is a patented FDA-approved addition to your current regimen of care that is trusted by over 45 professional sports teams in the U.S. to relieve pain, reduce inflammation, and increase circulation to maintain the health and performance in their athletes, providing earlier treatment for faster recovery. The HIVAMAT 200 Evident from Richmond.
All right. So on that video, they also have where you can have the electricity coming through your hands, or you can use applicator paddles, just like they use there on the video. And so the last thing I would like to talk to you about is the BIODEX system. So we use technology not only in treatment, but we're also using technology in regard to rehab. One of the things in sports medicine, and particularly with our athletes, is we want to do what we call prehab. We don't even want the athlete to become injured. We want to identify, and I'll just use the quadricep muscle, which is the thigh muscle, and the hamstring muscle, which is in the back. So the thigh muscle in relationship to the hamstring muscle, if we identify early, so when our athletes report for preseason, we BIODEX everybody just to see, is there a major deficit? And there's acceptable ranges of strength between the muscle in the front on the quadricep and the muscle in the back of the hamstring. If we see significant deficits, we already go ahead and prescribe rehab protocols so that that athlete doesn't end up getting a hamstring injury during the first game or at the beginning of the season, which is a very common time for a lot of significant injuries. So we try to identify muscle weaknesses and potentials for injury ahead of time. Then if an athlete does sustain an injury, we can use this device called the BIODEX. What this does is it takes out the momentum out of the equation. The athlete, this is what I say, the athlete can't fake it. So in other words, if she's screaming and grunting and moaning and screaming, it doesn't matter because the numbers don't lie. And so she can't just, so we get a very accurate reading, and we can measure the amount of force or torque that she's generating, and then we can identify at what areas in her range of motion is she weak. And then we can prescribe protocols based on that information to actually help our athletes. What we find is when an athlete is rehabbing one side of the body, there actually is a crossover effect, and the other side of the body even tends to get a little bit stronger as well. There are some athletes at FSU, and we have an outstanding rehab director that works with all of our athletes. He's a physical therapist, an athletic trainer, and a PhD. But what we find is sometimes the injured limb actually ends up stronger than the original, the opposite side. So we really use the BIODEX system every day in our clinical practice. So let me finish up with this last slide here. I'm just going to show you what the BIODEX looks like just for a minute, and then I'll be happy to take questions.
In 1985, BIODEX introduced the world's first multi-mode computerized robotic dynamometer. That event and subsequent firsts have made the BIODEX dynamometer the choice of the most distinguished clinics and research facilities around the world. Our 200 employees all strive to keep BIODEX at the forefront of innovation, effectiveness, efficiency, and reliability. That's why so many world-class facilities depend on BIODEX. Whether it's in the area of sports and orthopedic medicine, pediatric medicine, neurorehabilitation, older adult medicine, industrial medicine, or research, world-class clinicians depend on BIODEX to provide consistent, accurate, objective data. Objective data that provides the best outcome. Objective data that supports your research or treatment path. Objective data that distinguishes your facility from the rest. To stay competitive in today's dynamic physical medicine marketplace, you need to be adaptable. To be adaptable, you need equipment that can keep pace with progressive thinking and innovative therapies. You need dependable, versatile tools that give you the means to take on new challenges and extend capabilities.
Okay, so I think you guys get the gist of this machine. We can measure again any body part, any joint is in regard to deficits there. So what I would like to do is
You need a device that can be used to test.
This has been happening to me all day. So now what I would like to do is, and again, I know there may be some gators in the crowd, so love you guys too, or hurricanes, but I would like to go ahead and answer any questions that you might have. And so I think let's see. Okay, so are there any questions?
Yes, this is Tony Smith.
Okay.
A couple of the procedures that you had on there seemed like if you are on anticoagulants that it wouldn't be an issue. Is that true?
Again, I would tell you to Dr. Gandara probably is better equipped to answer that than me. But from what I understand from our physicians is actually that typically it's not an issue. But again, I would tell you to clear that with your physician that knows your health. But again, as far as I'm aware, that the dextrose is okay at that level. And I can defer to Dr. Gandara if he's available to answer.
Yeah, so it depends on what type of coagulation the patient has. For example, if you're in if you're on a baby aspirin or that might be a big issue. It's when people are in Coumadin or warfarin, we want to know what is your level. Sometimes I inject with people on that type of medication. If the level, which is called the INR, is lower for I have a threshold when I can inject or not. Some people with Plavix I have injected, but it have to be some structure that are superficial. I try to avoid deep structures. So it depends on what is your target. For prolotherapy like the dextrose, I don't think it's going to be a major issue. But if you're trying to inject a muscle, deep muscle or joint like the hip joint or put PRP somewhere deep, then you have to consider that risk of causing a bleeding. So.
Right.
Thank
you. All right.
All right.
So I have a question. I know that athletes are getting younger and younger, and they're getting more and more serious. Are you finding that these sort of things are okay for younger athletes as well, or more for the older athlete?
So thank you, Kate. So that's a really good question. What we're finding is that with the prolotherapy, it's safe, and again, you don't get those side effects of cortisone. You're actually promoting the inflammation process and hopefully kind of strengthening that tendon so that you don't have subsequent problem. So yes, in regard to safety, regardless of your age, yes. And again, I would defer back to your primary care, or excuse me, your orthopedist with that. But again, yes, it's safe. And here's the other thing with cortisone, you get some relief, but actually over time you can only have so many cortisone injections because it actually can necrose or just weaken that tendon or destroy it. But prolo, you can do prolo as many times as necessary. So again, you're going to be doing at least 3 to begin with in a series with about a couple weeks in between. So we feel like in Tallahassee, we feel like the side effects are very minimal, and it can be for all ages that are physically active. And again, you know, we're saying general statements, but I want to make sure I'm being very specific that, you know, each individual would have to consult their orthopedic doctor for that.
Yeah. Angela?
Yes.
Hi. Just one thing. I'm glad to, I wish they had this 20 years ago. I had to stop playing competition tennis, but I played competition tennis for a long time. But I want when you said the cortisone shots, yeah, I had to finally just give them up.
Right.
Yeah. And so, but this is exciting.
Shirley, here's the other good news. There's not going to be a quiz tonight. And the other good news is you can do Prolo now. You can do Prolo now. It's never too late. So, so that's another good thing. And again, I would just tell you to see your orthopedist, but it's not too late.
Oh, it's never too late.
Never too late.
Yeah. Thank you.
Hi, Angela. This is Mercedes.
Yes. Hey, Mercedes.
Hi. I thought I would just go ahead and verbalize my question. What does your data show prior to using these technologies compared to using these technologies as far as your sports programs and wins?
Mercedes, I'm sorry, I couldn't hear.
Yeah, Mercedes, you're really hard to hear, but it was in the chat. It says, what does your data show prior to using these technologies compared to using these technologies as far as aiding your sports program and wins?
So I didn't present the data here, but there is literature out there. Actually, Dr. Gandara showed you from the American Journal of Sports Medicine. These topics are covered in those journals. But I'll just say anecdotally, which I'm just talking about from my experience and over the years. I actually teach a therapeutic modalities class here at FSU, and I'm going to tell you that these therapies, again, I think they are, and including the PRP therapies and everything else that's been discussed, I do think it's significant because we can see that our athletes are able to participate longer and possibly avoid surgeries. So I do think that the data would show, and again, I'm just kind of generalizing, that yes, these therapies and these treatment regimens using this technology has significantly made an impact for our athletes. And the bottom line is, you guys, we have to answer to coaches as well as physicians and parents. And when you tell a coach that that athlete can still play, that makes a coach happy. Of course, we're doing that with safety. But yes, I do think it adds up in the win column. It does.
That's awesome. Any other questions? No. Thank you so much. That was amazing. It makes me want to go back. I was a college athlete, so I'm kind of like Shirley. I'm like, where was this when I was there?
Yeah. Well, let me just say thank you very much. I'm going to type in my email address, so if you have any further questions, feel free to email me. And again, thank you for this invitation. It was very nice to see you guys.
Thank you so much for joining us. We really appreciate your time. Wonderful. Well, we're going to get on to our last speaker this evening. Next up, we have Philip Lahey. Philip is the Senior Biologics Account Representative for Smith & Nephew, and he will be talking about rotator cuff, rejuvenile rotator cuff. So go ahead and take on over, Philip. Thank you so much.
Good evening. Pleasure to be here. I'm going to get my screen up for you guys before I get started. Alrighty. Can everyone see it? Good? Yes? Awesome. Again, thank you so much for having me today. I am the clinical educator specialist for Regeniten, which is the implant I'm going to be talking about today. And you guys set this up perfectly. This is for the dreaded, when all else fails, it's time for surgery. When we need a little help biologically, this is what this technology is used for. This was introduced into the United States in 2014. It was FDA approved. Did our first commercial case in 2015. I joined shortly thereafter. So this is very near and dear to my heart. Also, I found myself presenting in Colorado. I'm born and raised in Florida. I belong in Florida. I found myself presenting in Colorado last year. Came home with a large full thickness tear of my rotator cuff, a labrum tear, and a biceps tear. So I do not belong on the slopes. I know that now. So I learned my lesson. All right. So why was this created? So a mechanical engineer and a biomechanical engineer years and years and years ago were looking for something to create, and they didn't want to create a widget. They wanted to find out what was missing and within surgical services. So they went out to the leaders. They went out to all the thought leaders throughout the country, surgeons. What are you missing from your bag? What treatment do you just not feel great about? What patients do you feel like you can do a little bit better on? And it was consistently coming back on our mid-range partial thickness tears where they fail conservative treatment, but we want to bring them back. But at the same time, once you take them from a partial thickness tear surgically to a full thickness tear, you're going to be in a sling for 4 to 6 weeks. You know, the rehab process and full recovery can be anywhere from 6 months to a year, depending on comorbidities and age and a number of things. And then the secondary thing was our large tears and revision tears. So if anybody's had surgery, it didn't go great, it tore again, you go back for another one, it gets harder and harder to repair each time you go back in for surgery. So consistently, they were looking for additional options for treating poor tissue quality, smokers, diabetics, anything that would prohibit better healing responses. They were looking for something that they can localize on the injury site and promote healing. So with that being said, this is what we came up with. So on the far left side here, Dr. Gandara mentioned this as a treatment option. This is our tendinosis, tendinopathy. If that was my rotator cuff, I would be hanging out with Dr. Gandara all day long. I would not be opting for surgery. Even somewhere in the middle there, you see where that on the middle surface of that rotator cuff, there's a little a bit of a tear there. That would kind of indicate a 50% partial tear, let's call it. That's where it gets to the point where, do I put an anchor in this? Do I take it down? Do we want to go through conservative treatment? I've tried PRP, I've tried physical therapy, I've tried all the number of things. This fails, so let's go in for surgery. So our options are, once we're in surgery, there is something called a shaver. We just go in there and we clean it up. We remove some pain generators. We do a subacromial decompression. We free up some area. We keep our fingers crossed. We send you on your way. The nice thing about that treatment option is you're in a sling 1 to 2 days. You're back to activity within 6 to 12 weeks, which is nice. However, if it's too large of a tear, the tissue quality is poor, they're going to take a knife, they're going to complete that tear, they're going to pass sutures through that rotator cuff, they were going to re-secure it to the bone, and now we need a full-on response of reconnecting the rotator cuff back down to the greater tuberosity, which is that bony surface but beneath it. So again, you're going to be in a sling 4 to 6 weeks. Speaking from experience, the hardest part about the large full thickness tear, I had to sleep in a recliner for 6 weeks. It was not for me. It was not pleasant. Didn't sleep well. So that was going to be our focus, is our mid-range partial thickness tears and our large full thickness tears that we wanted to treat. Okay. So when coming up with what we wanted to create, we looked at the initial hypothesis: can we induce a healing response? Can we help induce a thickening of your native connective tissue? What would that look like? So on the left-hand side, that's stress and strain, and this is just a computer-generated mathematical study. And that's with the stress and strain. As it elongates, you see how it kind of disperses. It's not one local point of where all the energy is dispersed. On the right-hand side, we had the bursal-sided rotator cuff tear, partial thickness, and you see how it's very angry, very red, and there's a lot of stress and strain right at that injury site. So again, this would be a great option to start off with Dr. Gandara, doing our PRP, doing our physical therapy. But if we're not getting the desired response that we're looking for, what would happen if we induce or add 2 millimeters of connective tissue to the top side of that rotator cuff? What would that look like? So continuing on with our mathematical study, on the left-hand side over here, we show a bursal-sided tear. We added our 2 millimeters of connective tissue, and that's just you healing 2 millimeters of tissue. What is that going to do? And it's going to reduce that strain. On the previous slide, we were talking about stress and strain. We're going to reduce the strain on that rotator cuff by 47%. On the right-hand side over here, so this is a bursal-sided. Over here, this is representing an articular-sided tear. So we're putting something on the top to heal an injury on the bottom. So we add 2 millimeters of connective tissue on the top. We're going to reduce stress and strain on the undersurface of that tear by 40%, thus providing a healing environment, allowing to that rotator cuff, and what your body is always trying to do is to heal itself if given the opportunity. Okay, so those were our ideas. So here is the physical form. Here is the type 1 collagen we came up with. We tested a number of things. We tested human dermis, we tested synthetics, we tested porcine, we tested bovine, and that's where we ended up. So this comes from a cow's Achilles tendon, a closed medical herd out of New Zealand. We used the type 1 collagen from a cow's Achilles tendon, stripped away all the DNA. So when this is introduced to your body, it's not seen as a foreign object. It's not seen as a foreign body. It's not going to be rejected. The body sees it as type 1 collagen. I need that to repair soft tissue, and that's what it's using. Your fibroblasts and cells and blood is soaking in from the contact on the rotator cuff, soaking into this implant, and it starts replicating tendon tissue using that type 1 collagen. Okay, so it's runs linear, so up and down, highly porous, 90%. I like to use the example, it acts like a sponge. So your sponge in your sink, as you continue to use it, more and more germs get inside of it, it gets stinky, and you have to throw it away or wash it, what have you. Same kind of concept in that it's porous. All the cells are passing through this collagen implant. They're attaching to the collagen, to the porosity, and it starts using that collagen to resorb back into your body. So that big blue patch that you see on the right-hand side there, that will all be resorbed into the body. There's no foreign substance left over. So that whole blue border there is just type 1 collagen. Those little purple staples that go all the way around, it's called PLA, polylactic acid, which is just a polymer. It's been used in orthopedics forever and ever and ever. Within 6 months to 12 months, those will also completely resorb. The only thing that doesn't resorb, you see on the very bottom surface here, these are little bone anchors. And all this is doing is holding the contact from the tendon or the implant down against the bone. And now we're recreating a new tissue connection from the tendon down to the bone, thus reducing strain. Okay. So I like to share. So Buddy Savoy is out of Tulane University. There's a number of guys like that here in Orlando Health that I've had the privilege of working with. What Dr. Savoy gets is the worst of the worst. He gets only the revisions. He gets the stuff that's been treated. We've done 3 or 4 cases and we just can't get it down. Maybe they need a total, but they don't want, they're opting out of a total. They want to focus on healing themselves. So what he does, he just released a paper, 33 patients, 21 of which were all revision cases. And of the 33 patients, 31 of the 33 completely healed back. And generally with revisions, it can range anywhere from 60 to 80% of patients that have a revision case with rotator cuff, they can fail, especially as we get older, those comorbidities we talked about. So there's a high failure rate. So he's been using this technology for 5 years now releasing data that shows on my revisions, on my multi-tendon, 3 tendon tears, poor biology, smoker, diabetic. If I introduce this, I'm giving them the best possible potential to heal. Okay, so the progression. So day 1, we secure the implant over the patient's rotator cuff. First few days, it's not doing anything other than soaking up platelets, sucking up blood. It's starting to get organized. By 5 weeks, the integration of the collagen and tendon fibers are starting to get organized. And I'll show you a little, on the next couple of slides, I'll show you some histology showing where the cells and the collagen are starting to migrate. Once they get organized, organization creates strength. So day 1, it's just intimate contact through the tendons securing it down. 5 weeks starts to get organized. By 6 months, the collagen is completely resorbed, and by 12 months, all of the substance that's holding it down is all resorbed. So it's just your body healing itself. Okay, histology, my favorite. Early on studies, for those of you familiar with MRIs, all of our data was using MRIs to show we're thickening native connective tissue, but we were getting a question back from a lot of surgeons. Okay, I see that it's thicker, but is that edema? Is it scar tissue? I don't really know what that thickening is. It looks good, but I don't feel comfortable enough knowing that what I'm adding is actually connective tissue and it's native tissue that belongs in your body. Within 2 years of being with the company, we had 7 traumatic injuries. The 5-week patient was mine. It was a farmer had a large rotator cuff tendon injury, supposed to be in a sling for 4 weeks. On day 2, on a 3 centimeter large full thickness tear, he took his sling off and he started wrangling cattle and throwing hay because he was a tough guy. Unfortunately, he tore everything out of his shoulder. He tore his sutures, he tore everything out. Unfortunately, that happened, but on the flip side, we did get a biopsy showing that we took a biopsy from the induced tissue. It was already starting to meld in. We just saw the border, most of it already been resorbed in, sent that off to Stephen Arnosky, one of the leading scientists in the country, pulled up histology, and he showed the progression. Our 5 weeks, 3 months, 6 months, all the way up to 6 months. And the reason we know that's completely resorbed by 6 months is through the histology, that he took the slides and all the collagen had been used. And you see in the slides over here, so on the far left side, 5 weeks, it's pretty disorganized. You see a lot of fibroblasts and collagen migrating into the implant. 3 months, starting to get a little more organized. And by 6 months, the collagen is resorbed. And I like how everything is organized and a lot more anatomic, okay? So this patient is very unique. So this was out of Australia. This is before it was FDA approved. This young lady was a sports fitness CrossFitter. This is nearly an 80% partial thickness tear. Every doctor I would go and speak to, I would tell them to take this down, put an anchor in it, bring it down, because it has a very low probability of healing with something that significant. She didn't like that answer. She said, I'll just wait for it to completely tear out, and then we'll get the whole thing and we'll go through whatever. And after that response, he's like, we do have an experimental technology we're looking into. We can try it. I can't tell you for sure it's going to work. That is a significant tear. She decided to go with it. On the left-hand side, this is the undersurface of your rotator cuff. Huge, huge defect. And to our delight and surprise, this is 12 months out on the right-hand side, where it's completely filled in. We reduced strain on the top side, providing a healing environment, and she had the best possible outcome. Still surprises to this day that it completely filled in on the articular side. So how does that benefit our patient? How does that benefit the hospital system? As a medical device company, we do not recommend any changes to rehab protocol. We are not the experts. That's when you go to Dr. Gandara, that's when you go to your physical therapist and you ask for their recommendations. So what this is a grouping of 8 surgeons from around the country with 300 plus cases under their belt. They got together and they noticed on partial thickness tears where they do an online with Regeniten, that they were tending to get a little stiff. And they're like, why is there stiffness? And they came up with the fact that they're leaving them in a sling too long, because once you put the implant in, they were treating it like it was a full thickness tear and they were leaving them in a sling too long. So they actually developed this rehab protocol. So you have a mid-grade partial thickness tear, you have Regeniten put on, and they're treating it like a decompression, which was 1 to 2 days in a sling, and it's as needed after. You can come out of a sling in 3 days. Some guys, 5 to 7 days, if a little more conservative. But for our athletes, our overhead throwing, our baseball players, our football players that are pretty healthy, good, strong tissue that want to get back to a sport fast, they're coming out of a sling in 1 to 2 days. Okay. Phase 2, 1 to 6 weeks, we're going, again, you're staying in contact with your doctor, but we're starting our physical therapy. We're starting to get our movement back. We're starting to get our full rotation back. And now we're starting to strengthen the tendon that's been injured. And by the 6 weeks to 12 weeks, that's where it gets exciting. So again, on a full thickness tear, I mentioned to you guys a couple of times, 6 to 12 months full recovery, whereas we have a number of athletes with a medium-sized partial thickness tear, had Regeniten put on, and they were throwing by 12 weeks professionally. So it was kind of exciting for those of you who are sports fans. There've been a couple of times on ESPN, the MRI came back, so-and-so's got a rotator cuff tear, and then they come back and they're throwing 12 weeks. And they're like, obviously it wasn't a rotator cuff tear, because there's no way that patient would be throwing if that was what was the fact. So it's a great option when, again, conservative treatment fails, surgical treatment becomes the option, having that done, but your rehab protocols are as fast as you're going to get. Okay. So I told you the founder of the company was a mechanical engineer. So surgery, I don't know if you've ever, for those of you who have been in a waiting room for anybody in surgery, every minute you're holding your breath, it's stressful. So his goal was, great, we've developed a technology that can heal the rotator cuff, but is it going to take an hour to put in? No one's going to want that. I don't want extra surgery time. So he actually, the founder of the company, developed all the instrumentation you see here, and a general procedure from the time you cut skin, you start putting in the implant, to the time you're finished is anywhere from 5 to 10 minutes. We wanted it fast, reproducible, and easy, regardless of the skill set and training of the doctor you're with. So I'm going to talk you through, I have a small 1-minute animation to follow this, but essentially on the right-hand side here, this little small aspect right here, the implant's right inside of that. It will go through an 8mm or smaller portal. Generally, there's 3 portals in an arthroscopic. It's still considered minimally invasive, even though it's surgery. Goes through an 8mm portal in your shoulder. It's deployed. The implant pops out, looks like a postage stamp, through a portal just above that. That's 4mm. It's about half the size of your pinky nail. You will secure it with those little purple staples at the bottom here. We put 5 or 6 of those in, and then the big gun-looking thing here, they'll use that to do 2 bone anchors laterally, and that's your case. So the fast guys that are doing this, again, fast as I've seen is about 3 minutes, but generally when people are learning or taking their time is less than 10 minutes. Oop, go back. Okay, and I'll talk you guys through this as we're doing it. So here you have the patient in the lateral position. There's that 8mm portal I was telling you about. There's the 4mm portal I was telling you about. So the implant goes in through that lateral position, slides in, squeeze the trigger, implant pops out, held down. The resorbable staples are securing the patch to the rotator cuff. Last but not least, you'll come in with 2 bone anchors that secured into bone, and then the healing response begins. Now we're having an induction and healing response through what they call intimate contact. And that is all I have. So if you guys have any questions, I'd be happy to answer that for you.
I'm looking through the chat right now to see, don't see anybody want to come on and ask any questions. So for athletes, again, what's the amount of time after having this procedure done? How long until they're really back full force into their activities?
It really comes down to the severity of the injury. So on one of the athletes I mentioned before was like a 30–40% partial thickness tear. He was in practice throwing by 12 weeks. And he was back in the lineup by 6 months. So that was a pretty fantastic outcome. For me, my experience, I had a large full thickness tear. Generally, they ask you to go 4 to 6 months before they get back to anything significant. But for whatever reason, the other thing that's coming back with this is obviously there's a lot of focus on opioid dependency and pain meds. For some reason, patients are coming back after having this technology used, saying they're not having any pain. I had a large full thickness tear, labrum tear. I didn't take one pain med. Obviously, pain is subjective, but it's consistently coming back, showing that patients aren't having a lot of pain, so they're not needing it. There's a number of surgeons, one specifically up in Boston, Scott Sigman, that refuses to prescribe pain meds on a partial tear with an onlay. So it could be 6 months for some of you athletes. For me, I played golf with a funky looking swing, but golf nonetheless, 3 month post-op on a large full thickness tear.
Wow. And so when do you really start looking at this? Is it any kind, just the minuscule amounts of tear, or does it have to be a certain amount that it's torn for you to be able to go in and say, yeah, this is when you need this?
Great question. So again, if it's a tendinopathy, which is just a a very minor bursal-sided inflammation, some irritation, you're having some pain, I would go and I'd hang out with Dr. Gandara, and I would avoid, like, being for a person, I hang out in surgery all day, and I teach the technique, and I teach surgeons how to do this. Surgery is the last resort. You want to go the route of physical therapy, injections, and then if that fails, then we go on to surgery. So once we progress through that, and then I'm still having pain, I'm having weakness. My biggest issue, the reason I knew I needed physical therapy, surgery, I reached out to get my Starbucks coffee, and being that there was a detachment, my arm completely dropped. Just the weight of the coffee cup made my arm completely drop out. So for me, I drink a lot of coffee, so I had to have surgery immediately. But if I had a partial tear, I would do my very best to exhaust all conservative treatments before I came in. But again, we're in surgery. Once you're in there, you're already on the needle. If it's a low-grade partial that they decided to, and Dr. Gandara mentioned calcific tendonitis, where it's a calcium deposit, it creates a crevice. And a lot of times what guys do is they just remove the calcium deposit, and then they go about their business, but there still is a defect. What they're doing with those is they go in, they trephinate, they use a needle, they break up the calcium deposit, and then they'll do an onlay of the implant over the top of that to make sure they have a good outcome long term.
Awesome. Wonderful. Wonderful. Any other questions?
Hey, Philip, I just have a quick question. Is the company in the future trying to use this for other pathologies like Achilles partial tear? So do they have any plans of using it for that sort of things?
I appreciate you asking that question. I'm not allowed to say that unless the question comes up. Yes, so the data that we have right now is 6 years out for rotator cuff. However, the implant itself is FDA approved for every tendon in the body. The only thing that restricts us from going and marketing this to every tendon in the body is the bone anchor. It is specifically designed for the greater tuberosity. So therefore, that's where we're specific to it right now. But there's a lot of independent studies right now. The big topic, there's a few tendons that are drawing a lot of attention. Within the hip, they have something called the glute medius and glute minimus, which is kind of the rotator cuff of the hip. Patella tendon, quad tendon, Achilles tendon, distal bicep, distal tricep, a number of places that guys are using this. Again, it's considered off-label, so it's at the doctor's discretion if they feel like this is, as far as safety goes, it's completely safe. It's FDA approved, but that's the only reason we don't market towards every tendon in the body.
Interesting. And one last question, and this kind of goes out to all of our speakers, and I'm so glad that Mercedes actually asked this. We have a member of the chamber called Crooms Academy, and it's one of our magnet schools here in Seminole County. And it's all IT magnet school. And so we deal with these students, and when we go back to talk to these students that want to possibly pursue a medical field career in these type of technologies, can you give me some of the tips and, tell them staying on top of the latest and greatest? Give me a little bit of guidelines of what we should be telling these students about these technologies and how to maybe get into these fields.
I can share my experience, especially for those of when you hear of medical technology and product sales and all these other things. I came from the background of a clinician. I started off at Orlando Health as a surgical technologist. I specialized in a little bit of everything. I bumped into a representative that were doing spinal fusions and baskets, and I fell in love with it. My wife is a physical therapist, so I wandered into a couple of cadaver labs with her. So I pursued the surgical aspect. From there, I got into, I used LinkedIn and a number of online recruiting sources, and like we're doing here, networking and just meeting as many people as possible. That got me a phone call with a recruiter, that got me a phone call with a manager. And from there, I've been in medical sales and within the industry for 10 plus years. That was my path. That's for people within this that's kind of a rarity. Most times for people that are in medical sales and these technologies, they go the route of, I got my undergraduate. Most of them require at least a 4-year degree. And then you attack LinkedIn, you attack networking. There's a couple of sites called MedReps where you can use that, where you pay a service. Well, they'll actively go out and find open positions for you. and they'll get you in that entry level stuff. It's a hard industry to get into. It's long hours. It's challenging, but I wouldn't have chosen anything different. I'm very thankful for what I do. I enjoy getting up every day and doing what I do. But there's not one way to do it. It's, for the most part, larger companies, Smith & Nephew, the Stryker, the Arthrex, the J&J, they will require a 4-year degree. After that, it's just hustle.
Wonderful. Any of our other speakers want to come on and answer that one?
So yeah, on my advice, I would suggest if they're interested in the sport medicine field or such medical technology field, I have had some high school students who shadow me in the clinic, and that way they can get exposures and learn what I do, and I also do the procedures. If they're with me, they can see what I'm doing with those type of procedures. There's some medical associations that they can include some students, and they can also start getting some updates and information about the field. They also will have a taste of what's the process of becoming, if they want to be a physician, how long it's going to take, and they have an idea of our daily life if they want to come into the medical field. But that will be an area that they can ask the physician. They call the office and ask if they can shadow, and some physicians are okay with that, and that way they can get the exposure and experience they want to know.
Wonderful. Well, we might be calling you. Just be warned.
I would like to just show you one thing. I'm just going to talk about Florida State, what we have. A lot of students want to major in, they can major in exercise physiology, biology, chemistry, but we have an athletic training degree here at Florida State. And so it's a whole bachelor's degree. And as you can see, again, this covers general university requirements. But as an undergraduate student, and again, I think we're the only one in the country doing this right now, and certainly within our state we are. But our students can have a sports medicine, again, as an undergraduate, a sports medicine foundation. These are people that are clinically active right now teaching these courses. So this is a general sports medicine class. I teach this one as a treatment class, kinesiology, anatomy, and movement. This is an acute care. We're talking about bleeding and trauma. This is a general medical course, orthopedics, administration. And then our students also, they specialize. So if they want to work with the athletes in their clinical rotations, that's here. They can be pre-physical therapists, go on to med school, or go on to PA school. So this is an undergraduate degree here at FSU. And again, they do need to shadow and try to be involved in club organizations as well. So I just wanted to show you that here at Florida State, we do have a whole bachelor's degree that the high school students may want to think about in coming. And now that's on our website for Florida State, and I can put that in the chat as well.
Wonderful. Yeah, that's great. Great information. Well, we're running out of time, so Jessica, if you'll bring up our last few slides. Thank you to our speakers this evening. What great information. It was a really great event this evening. The topic was informative, and our speakers, thank you so much. You all three did a wonderful job, and it was really neat to see how you all kind of tied in together, you know, so it was really informative. So I appreciate your time this evening. Thank you so much.
Thank you.
Outstanding. So I just want to wrap things up this evening. I want to say thank you to my wonderful committee here on the SeminoleTech committee. Again, I'm Kate Crockett. I'm with RB Advisory. We are a cybersecurity firm. Andrea Mahoney from Certified Computer Solutions. Thank you. Rob Gross, Complete Communications. Rahil Noor, TaxLeaf. Garrett Coaster, GK1. Brian Nagel from Real Time Services, and our newest member, Tony Smith from Mobot. Thank you so much for all of you guys. I really appreciate my team, and I couldn't do it without you. Our next event will be next month. We are always on the first Wednesday of every month, so it will be October 7th. And next month, we're gonna do home technology, so that will be kind of fun. Come back and join us. And thank you again to our sponsors, Culture Solutions and Complete Communications. We couldn't do it without you guys. And also, we are looking for another sponsor. So if somebody out there has a company that you're interested in being a sponsor of SeminoleTech, I can send you some more information, or Jessica can. So just email us and we'll get that over to you. But since we are pressed for time, we were going to try and do some breakout sessions, but I don't want to hold everybody's evening up. So I'm just going to say thank you so much to everybody this evening. Make sure you sign up and register for all of the Seminole Chamber events that are coming up. And hopefully we will see you next month for Home Tech. Thank you, everybody. Have a great evening. Bye-bye now.
Thank you. Have a good night.
Bye-bye.